Yes, welcome you all wonderful people hearing me out here. So let's get started with a single MCQ punch that will be taken on lung volume and capacities. Okay, so a single MCQ, but we'll be covering lots of theory out of it, right? So this is my Telegram channel, boys and girls, the Telegram group. For I will be downloading this particular question in the form of PDF. So if you are interested, so you can just get connected to me through this Telegram group. So let's get started. The question says that there is a 30-year-old woman who is referred for a life insurance policy she's taking, and for that she's coming for a routine physical examination. No history of smoking. There are vesicular breath sounds at the periphery of the lung with auscultation, and spirometry shows a tracing. So this is the tracing which is being shown for the particular patient. Out of this, the question says that which of the following is your expiratory reserve volume? The options given are C, D, okay, E, then you've got C plus D and E minus D. So C plus D and E minus D, right? So a very important question, boys and girls. This is very important. The lung volume and capacities, they are not only important in physiology but also when you deal with your respiratory medicine. This question comes as a clinical based question, which I have taken the history. You may be given history of smoker, you may be given history of occupational lung disease. It also comes in the form of calculation based question. Right now the question says ERV. You know that what is FRC? FRC is nothing but is expiratory reserve volume plus residual volume. So your ERV becomes FRC minus RV. So this is my FRC minus RV. That is the correct answer is E minus D. Right? So a very basic question, but just put forth in a way which can be little confusing. Now let's get started. As far as FRC is concerned, it is also called as the relaxation volume, because it is the volume of the air which is present in the lungs when the entire respiratory system is relaxing, right? It is end expiratory position. It is also a volume that maintains the elastic recoil, okay, of the lung and the chest wall. You know that both of them have got elastic recoil tendencies, but in opposite direction. It is maintained by the volume which is your FRC. As far as the vesicular breaths which were given in the question, this vesicular breaths, you know that normally also when you auscultate your respiratory system, you are going to get vesicular breath sounds all over the chest, except over the tracheal region where you get the bronchial breath sounds, right? So what is the difference between your expiratory reserve volume? It is the maximum volume of air that can be expired out, which will be more than the tidal volume. And after this forceful expiration, whatever air is remaining will be your residual volume. So remember, it will be at the end of forceful expiration. But if I consider my FRC, right, if I consider my FRC, it is the volume of air which is remaining in the lungs at the end of my tidal or a normal expiration, right? Now let's look on to a topic. This is very interesting topic. You understand. See, this is the vital capacity. That is, I've asked the patient to take a breath and then expire out. Here I have not stretched out the forced expiratory time. I have not stretched out. But when you ask the person to take a deep inspiration and continue this is called as the forced expiratory time, which is around 6 seconds. And if it is more than 6 seconds, definitely it is an obstructive airway disease. Now this particular thing which is taken graphically is called as our timed vital capacity. So this is a simple vital capacity where this is not stretched out, right? That is, the expiratory limb is not stretched out, whereas in the timed vital capacity, or which we called as the forced vital capacity, it is stretched out. That is the basic difference between both of them. So vital capacity is a static capacity, whereas forced vital capacity becomes dynamic, because here the time factor is taken into consideration. So when you ask the patient to expire as complete as possible, as rapid as possible, and as forcibly, so completely, rapidly and forcibly, these three adverbs when you are putting on to your expiration, it is going to become a dynamic lung volume and capacity, that is forced expiratory, forced vital capacity. Now what you will do over here is, why are you interested in your why are you interested in this expiratory limb? Because you have to consider the obstructive and the restrictive air disorders. The basic characteristic with the obstructive airway disorder is a difficulty in expiration. There is an increase in the resistance to the airflow, especially during expiration. So what happens is that over a period of time the air keeps on getting accumulated, and there is an increase in the compliance with increase in the residual volume, TLC and FRC. In restrictive disease there is a poor compliance, right? There is a poor compliance because there is a difficulty in inspiration, right? So यहाँ पर there is going to be decrease in the residual volume, decrease in your TLC and your FRC. But what is more important to be considered is what we call as the Tiffin use index, right? Your Tiffin use index, that is FEV1 to FVC. That is the characteristic feature of the obstructive and the restrictive disease, that is the FEV1 to FVC ratio. So remember, when you consider FEV1, that is the numerator part, you are only considering the expiration. But what is FVC? It is volume of air which is taken in and given out. So यहाँ पर you are considering both inspiration as well as expiration. Now in the obstructive airway disease, the basic problem is with the numerator. That means the fall in the numerator is much more than the fall in the denominator, right? This is what is to be understood, that the decrease in the numerator is much more than the decrease in the denominator, and therefore the FEV1 to the FVC ratio is markedly reduced in obstructive airway disease, which is the cornerstone for diagnosis of obstructive airway disease. Whereas in the restrictive disease, okay, there whatever less amount of air the patient is inhaling, he is able to expire 70% of it. So there is not much significant fall in the numerator as compared to the denominator. Therefore, if you consider the respiratory disorders where there is restriction or restrictive disorders, the ratio is normal, or surprisingly it can also be increased. So very importantly, just look at the numerator and denominator, who is falling more. If the numerator is falling more, it is definitely obstructive, right? Now if suppose there is a confusion in the obstructive airway disease and you are not able to identify whether it is COPD or whether it is asthma, just go for a post bronchodilator reversibility test. What is that test? You give a known dose of a beta 2 agonist like salbutamol to the subject, take a pre-bronchodilator recording and then a post-bronchodilator recording, and if there is an improvement in FEV1 or the Tiffin index equal to or more than 12%, it is reversible airway obstruction, which is nothing but asthma, right? Now characteristically, you have seen that in the restrictive airway disorders, you will find that the graph is almost similar to that of the normal one, with just a decrease in the height. Okay, just a decrease in the height because there is a decreased amount of air, so you cannot reach up to your PFR. Whereas in the obstructive airway disease, there is basically flattening or more scalloping or a dog-shaped curving, which you say in the obstructive airway diseases. This is called as a clinical spirogram, right? This is called as a clinical spirogram, where on the x-axis you take time and on the y-axis you take the volume. So this is giving you a ratio of FEV1 to FVC. This is clinical spirogram, whereas this is your flow loops. Okay, these are your flow volume loops. Remember, on the extreme right is the residual volume and on the extreme left is the TLC. We are not able to measure TLC and residual volume on these parametric maneuvers. This is just for your understanding. So we've already learned that all the lung volume and capacities can be measured, but you cannot measure residual volume and TLC. But this is for our understanding. So from the baseline, when we go down, this is inspiration. Right, this is inspiration and this above is expiration. This portion up to the peak of PFR is called as effort dependent. Right, it is called as effort dependent. That means if the person will expire out forcefully, the height of PFR can be increased. However, once the peak of the PFR is obtained, this portion becomes effort independent. Another way of remembering, remember, large airways, large volume of airs. Small airways, small volume of airs. Right? So PEF, this portion is effort dependent and this is effort independent. Again, very important MCQ. This is something which is called as your pneumatograph. The pneumatograph depicts that if you keep on increasing the effort for inspiration, there is going to be better and better inspiratory curves which do not merge with each other, right? They do not merge with each other. On the contrary, when you consider the expiratory curves, you will see that there is a distinct expiratory curve up to a point you reach your PFR. That is effort dependent. The moment you come to effort independent portion, that means small airways and small amount of air, whatever may be the amount of effort, these curves are not distinct, they merge on. So this is expressed in the form of a pneumatograph. Now, what is, like whenever there is or airway obstruction, it could be a large airway obstruction, it could be a small airway obstruction, or it could be a combination of both. How do I come to know? Now just remember that when there is an only this is the normal PFR. Okay, this is normal PFR up till this point, and I can see that in this graph there is a decrease in the PFR, whereas there is no concavity in the small airway portion. That is the effort independent portion, does not show any change in the shape. So when there is only a decrease in the height of the curve as compared to normal, that indicates a reduced in PFR and that indicates large airway obstruction. Whereas if the peak of the PFR is normal but there is concavity, that means there is basically small airway disease which is resulting in this typical concavity or the scalloping. So less volume of air where there is effort independent role, this concavity suggests me that it is small airway disease, right? But if there is only a decrease in height but no change in the shape, large airway disease. And when there is a combination of both, that is a decrease in the PFR plus a defect or the concavity, it indicates a combination, that is both large and small airway obstruction. In the restrictive airway disease, there is going to be no change in the shape, there is just a decrease in the height. Obviously the height will be less, because what happens in restrictive lung disease, there is a decrease in the compliance. That means the volume of air which can be taken in by the subject is less. Obviously when there is a less in volume which can be inhaled, you cannot develop more effort, right? You cannot develop more effort to obtain a high PFR. Okay, so restrictive में basically problem क्या है कि PFR is reduced. Why reduced? Because ज़्यादा PFR करने के लिए you require more volume of air, and patient with restrictive lung disease do not have more lung volume, they have got less lung volume, right? So thus a decrease in the height, otherwise no concavity. So remember that the lung volume and capacities, they are very important. They come as graph based questions, they come as calculation based questions, they come as image based and clinical history based questions, important in physiology, pharmacology as well as your respiratory medicine. So this is all for this MCQ. If you want a PDF of this, you can join to my Telegram link which is being given at the beginning of the session which I started. Happy learning. Thank you all.